Yes, hello. My name is Basil Williams, and I would like to thank the Argentinian Society of Ophthalmology for giving me this opportunity to speak with you today about retina surgery in patients with intraocular tumors. Here are my financial disclosures, which are not relevant to this talk. So the goals and the objectives of this talk are to highlight the unique risks that are associated with surgery in patients with tumors, to discuss some of the precautions, and then highlight the types of surgeries that we perform in these scenarios. So some of the risks associated are tumor seeding, which is obviously the most concerning because that potentially offers an opportunity for an intraocular tumor to escape the eye, potentially go into the orbit and metastasize. The potential for vitreous seeding as well. Then there's the issue of proliferative vitreoretinopathy, which can be from liberation of actual tumor cells or RPE cells that can sit on the surface of the retina and contract. And then there's also the long-term considerations of radiation and how the surgery can kind of modify some of those effects. So there have been a few case reports about extraocular extension or vitreous seeding from tumors, but this is something that tends to be particularly rare. And so by performing or by approaching things in a certain way, you can really reduce the risk of extraocular extension. So the first thing that's most important is identifying the location of the tumor. And so this can be done by clinical examination as well as ultrasound to make sure that you're not placing your trocars in a location that might be associated with the tumor. Unfortunately, I have seen a couple of cases that have been referred to me by vitreoretinal surgeons who thought there was just a retinal detachment without realizing there was an underlying tumor. And when they placed the infusion line, it went directly into the tumor. So obviously that's a complication that we would like to avoid. So here's a video of my actual first surgical case of an intraocular surgery. And this kind of goes over some of the important factors that we pay attention to. So first, there's a conjunctival piridomy done in the areas of trocar placement. And this is done so when the trocars are removed afterwards, there's no potential residual cells that are hiding underneath the conjunctival space or trapped in location that could potentially grow into viable tissue. Next is cryotherapy. So as soon as the trocars are removed, we perform a double freeze thaw cryotherapy technique for any potential cells that can be at the site of the sclerotomies. So that way it can freeze and on the thaw, kill those cells. And then the last step that's important is suture closure of the sclerotomies. So that way there's no potential opportunity for cells to escape the eye further on down the road, depending on the pressure of the eye. And then obviously we close the conjunctiva as well. So there's a number of different types of surgeries that can be performed. So obviously fine needle aspiration biopsy or vitrectomy assisted biopsy. And sometimes after biopsy, you can develop a vitreous hemorrhage or rhegmatogenous retinal detachment that needs to be repaired. Many tumors have exudative retinal detachments at the time of presentation, and they occasionally need to be repaired as well. And then there's options for radiation retinopathy prophylaxis, potentially by doing endoresection of the tumors. So here's an example of a vitrectomy assisted biopsy. And you can see basically have a light pipe set up, and usually there's an infusion line in place. Often the infusion line is turned off. However, the pressure in the eye is then increased, usually to 60 to 80 millimeters of mercury upon needle withdrawal from the tumor to reduce the risk of any ongoing hemorrhage afterwards. And you can see here, there is really minimal bleeding at the time of removal of the needle because of control of the pressure. So with vitrectomy assisted biopsy, we know that vitreous hemorrhage immediately afterwards is pretty significant. However, it is only requires a vitrectomy to be done in usually less than 6% of cases, at least in the literature. And rhegmatogenous retinal detachment development afterwards is also fairly rare. So what about rhegmatogenous retinal detachments? This is rare to happen in the setting of a choroidal melanoma, even after a fine needle aspiration biopsy. And that's thought to be because the tumor itself provides kind of like a buckling effect and a little bit of a tamponade for the break at the site of the biopsy. However, Sometimes, especially after radiation, if there is a hole present in the retina or areas of thinning, and an increased exudative detachment happens at the time of radiation, that can lead the fluid to develop underneath the retinal hole, and that can cause subretinal fluid to develop. Or if the tumor shrinks rapidly due to radiation, then the tumor is no longer providing as strong of a buckling effect in that scenario. Now, if the break is very anterior, a scleral buckle can be a very appropriate approach, and that avoids the intraocular component of surgery. However, sometimes pars plana vitrectomy is required. Additionally, with exudative retinal detachments, which when they need to be repaired, can be repaired in a similar way, we know that these are present in tumors very often. Up to 75% of melanomas can actually have some level of an exudative retinal detachment associated at the time of diagnosis. Now, we know this can get a lot worse after radiation treatment, especially as the tumor cells lyse and kind of release fluid. So it's due to a breakdown of the blood-retinal barrier, and this is more common in larger tumors and more significant of a problem in larger tumors as well. We also know that while the exudative detachment often goes away on its own, the longer it's present, the more damage it does to the photoreceptors, and that can have a negative outcome on the vision. Therefore, by intervening earlier, you can potentially reduce the risk of damage to the vision down the road. So here's a video of actually that first case that I showed you, where we go with an internal approach to the pars plana vitrectomy. And I think one of the downsides of this internal approach is that you're making a break in the retina, especially in the case of an exudative detachment where one was not previously present. This potentially allows tumor cells and RPE cells to escape from that area of the break and cause PBR. So you can see in this case, we place intravitreal Kenalog in order to make sure that a PVD had been completely created. Intravitreal diathermia is performed, and then an air fluid exchange is performed in order to completely flatten the retina. Now, depending on how large the tumor is and the concern at that time, you can consider placing a tamponade as well. And in this case, you can see we added endolaser around the area of the tumor and around the retinotomy site in order to reduce the risk of radiation damage in the future, as well as to close the retinotomy site. You can also approach this from an external approach. So here's a patient that had been previously treated with radiation, and you can see a significant exudative retinal detachment with hemorrhagic components shortly after the plaque was performed. So here's what we did from an external approach. You can see first there was a limbal incision that was made and an anterior infusion line was placed. There is a 360-degree peritomy, and you can see part of the Wexel was placed to absorb some fluid. Scleral cut down was performed, and then some diathermy was performed on the choroid to reduce the risk of bleeding. We pre-placed a stitch to close the sclerotomy, and then we started draining the fluid. Now you can see this is something that we pretty much only do after the tumor has been treated, because again, we don't want any tumor cells to be present in the orbit. And then we suture our sclerotomy and do a cryotherapy to that area as well. There are some new devices that have been developed that actually have a guarded needle, so that way when you drain, you can actually withdraw, sometimes even with your vitrectomy machine, to reduce the risk of seeding of the orbit. And you can see the outcome of this patient after silicone oil was placed. We did enter the eye because of the retinal detachment component and the possibility of additional exudative detachment developing. And so we placed oil tamponade. Now, we know macular surgeries can be performed in these patients for epiretinal membranes or macular holes, and usually paying attention to the pre-op surgical considerations that we've already discussed, patients can do very well. So here's pre and post radiation treatment for a patient with a large uveal melanoma. And you can see a very small macular hole prior to treatment. And actually immediately after treatment, the hole got bigger, but we don't have a great scan of that. And you can see here a post-treatment with 20/30 vision. So next, in the setting of radiation retinopathy, we know that animal models have shown that silicone oil placement reduces the risk of radiation damage to the other parts of the eye. And so there are some centers that actually place silicone oil with vitrectomy at the time of plaque placement to reduce the damage of radiation to other locations, particularly the macula. This is also, so simultaneously, if there's an exudative retinal detachment that's present, that will be fixed at the same time. Now, from an endoresection standpoint, there are a number of steps in this technique. This is something that is somewhat controversial, at least in the US, because of the concern for dissemination of tumor seeding. At least in the US, it is primarily used in patients that have already been treated with radiation and who have large tumors, and there's a concern for significant radiation retinopathy to develop. And so here's a video courtesy of Andre Vidoris from the article published in the International Journal of Retina and Vitreous in 2017. And so you can see that first a core vitrectomy is performed, making sure to get all of the hyaloid because any residual vitreous that is left can be quite problematic. Depending on the location of the tumor, the next decision is where to make the retinectomy. And in this situation, they went with a peripheral retinectomy to then fold the retina over to access the area of the tumor. You can see there's actually quite a bit of hemorrhage that's present. So all of the hemorrhage and the vitreoretinopathy and the traction is removed first. And then attention is drawn to the choroid, where diathermy is important to try and reduce the risk of bleeding. Next, the tumor is approached to make sure that you remove as much of the tumor as possible, with the goal really to try and remove all of the tumor down to the bare sclera. At this time, laser is performed to the area of the bare sclera to try and make sure there, that any potential residual tumor cells are also killed. Next is going to flatten the eye. So going back to the other side of the retina, putting in a PFO bubble to flatten things out. And then once that's flattened, adding laser to the surrounding retinal tissues. And then you can do a direct PFO to oil exchange, or sometimes people do a PFO to air exchange, followed by a silicone oil exchange afterwards. And a long-acting tamponade is particularly helpful in this situation because of the risk of proliferative vitreoretinopathy and recurrent retinal detachment. So here's an example of a patient who had an endoresection, and you can see kind of the pre and post. And you can see that even with a large tumor like this, so close to the optic nerve, with considerable concern for radiation papillopathy and radiation maculopathy, you can see that the macula is relatively preserved. Now, it is important to know that this procedure is not without any risk of complication, as there can be recurrence and extraocular extension. And when you have exposure or access to the choroidal vessels, there's a possibility of an air embolus that can develop as well. So in conclusion, intraocular surgery is generally safe in people with intraocular tumors. It is important or helpful to utilize appropriate precautions, especially if they have not been treated with radiation yet. And that includes performing a peritome, a cryotherapy in the location of the sclerotomy sites, and suturing the sclerotomies, obviously after you've demarcated the area where the tumor is. And then last, consider using a more aggressive tamponade in these situations because of the increased risk of vitreoretinopathy. So I'd like to thank you for the opportunity again to speak with you today. Here's my email. In the event that you have any questions or interesting cases that you would like to share, I would be happy to discuss them with you. Thanks so much, really appreciate it.